Hi, everybody. Thank you for joining us today. We are here to talk about the mountain model, which we created. But first, let me introduce you to Jane. Jane is the visionary in our partnership, and it was Jane who challenged us to come up with this model. Jane?
Hello, everyone. I am so honored to introduce you to Julie. And Julie is the creator in our partnership who was really able to use her experiential wisdom of over 30 years in the nursing discipline to put this model to make it, but also to be able to get it into the academic and practice settings that it's in today. And we're excited to present you with an overview of this model.
So, the way this came about was Jane and I were writing a textbook. This is a textbook for pre-licensure nurses. And we were struggling because we wanted to introduce nurses to research, to evidence-based practice, and to quality improvement. And we just could not find a model that we felt served that purpose. So Jane asked me, why can't we develop our own model? And I had a million reasons why we couldn't, of course. This is how our partnership works. And however, I did start thinking about it. And I do my best thinking when I'm out on runs. And so ultimately, I was able to come up with this model that really fuses evidence-based practice and quality improvement. So shall we go ahead and get started with the nitty-gritty?
Yes.
All right, bear with us while we share our screen. I'm just going to share my, there we go. So, go. As we said, we were struggling to explain what we saw as a seamless process from research to evidence-based practice. And Jane will just we'll kind of go back and forth on these slides.
Absolutely, Julie. And then from evidence-based practice to quality improvement. So there are issues with these two distinct paradigms of evidence-based practice and quality improvement, which, as you likely know in your DMP program, these are built upon research, or should be. So evidence-based practice lacks the robust sustainability components that are there in quality improvement methods. And there's unclear specifics of how organizations determine whether the practice was effective and continues to work in evidence-based practice. On the other hand, with quality improvement, that favors internal, or like we sometimes say, in-wall evidence to your institution, to the exclusion of external evidence, including research evidence beyond the walls of your institution. And also with quality improvement, we risk implementing ineffective solutions that waste resources because they are not based on the best available research evidence. And so what we saw as a problem as educators, editors, practicing nurse practitioners is that these needs should not be uncoupled. They needed to be merged. And that is what the mountain model is that came to Julie on the run, putting these together, because it's really not an either or, it's a yes and. We need evidence-based practice and we need quality improvement. And quality improvement has its origins in industry. And so that's great, but that's not what we're doing when we are impacting a practice change. So we really need to have that practice that is on the base of evidence. And with that, we look forward to showing you these levels and how they build upon each other.
So of course, just as you would do, we went to the evidence, and like we said, we did not find any type of fully integrated model that we could work with. So this led us to an opportunity. One in which, like Jane said, we put all the components of research, evidence-based practice, and quality improvement together. One that can help us systematically and simply move from the generation of research to its application in practice, where it includes continuous monitoring of that application to ensure the highest quality care and one that has dissemination at the top to impact exponentially that movement of research into practice. Because right now, it takes 15 to 17 years for our wonderful research scientists' work to be put into real world practice and finally start making a difference in patient outcomes.
And that is what your primary job will be as a D&P prepared nurse. You will be an expert in moving that research evidence and putting it into practice so that we can improve those gaps that are there and optimize care. So here's the mountain model. And as you see, the first level is external research evidence on the bottom, because this is the basis of every practice change that we should do. The second level is evidence-based practice. And this is the three-legged stool. This is the critical appraisal of a body of research that's synthesized, combined with clinical expertise and patient preferences and culture. And so when we put those three together, we have really solid literature that says it improves outcomes and it saves money, which is very important because we have a lot of constraints with money in healthcare, obviously. As you see off to the left side, there's that half circle there that says more research or identify a new problem. Because when you move to level 2, sometimes what we find is there isn't enough robust research to support a practice change. And so, like Julie will often say, find another problem. We have plenty of them in healthcare, right? So you can do that, or you can partner with PhD colleagues and people that have expertise in research to do a research study focused on that. But once you have the evidence-based practice that's based on that research evidence, then we move up to this third level, internal evidence. And this is something I can tell you as someone who oversees a D&P program that we often miss, but it's critical. Oftentimes D&P students will have an area of passion or interest that they decide this is going to be my project, but they don't have that internal evidence to support the need, and then their stakeholders don't buy in or don't want to pay for it. So it's really key that you have your problem that you identify and you build up to that internal evidence, which includes cost, quality, and safety metrics, which are really important to a practice change. And then equally important, and this is something that I learned from Julie a few years ago, is about purpose and aims. So often D&P completed initiatives don't have a clear articulated purpose and aims written in a measurable, smart format. So specific, measurable, achievable, relevant, and time bound. So we really have to do that. Then up right before the snow cap, you see the quality improvement level. And so this is where the two, and to the left, you see a pathway that is going between them. And it can look like it's a unilateral move, but it's fluid. You can go up and down the mountain depending on what's going on with the initiative. But this is where you use quality improvement methods to look at your continuous monitoring over time and have sustainability. Gone are the days that we're going to have quasi-experimental research methods in a D&P project, like pre-post. You have to have iterative changes over time. Now, something that's really important before we move to the snow cap to explain clearly here is that this is an umbrella framework, the mountain model is, meaning it is putting the main goal, one of the main goals is to put EBP together with quality improvement. And so you can use other frameworks. The Iowa model, for example, would fit down here on level 2 to get that EBP practice change. And then you can use some of these that are listed out or more at the quality improvement level to test cycles of change over time with implementation science principles, not implementation science because that's a form of research, but using those two together. And then we get to the snow cap. And as Julie said, another main focus of the mountain model is dissemination. So something to pause and consider is that just like the bottom of the mountain, that is our base of research evidence, EBPQI initiatives are being published. Julie and I recently looked into this at many journals, and they are important because they are transferable. And we'll talk more about that. But we hope that you're thinking, even though you may be in your first EBP or QI course, we're not sure where you are in your D&P program, it's very important that you think about your project, your future project, in terms of being able to disseminate it, because as a nurse leader, others need to learn from your work. So that's our brief view here. Julie, anything to add to this before we move on?
No, I think we'll cover each layer in a little more detail now. One thing that we hope you will agree with us on is the inclusion of the P. And oftentimes we have seen models that label themselves as evidence-based process improvement or evidence-based quality improvement without the P. And we like to think of the P as the we, as the nurses, as the people who practice. And when we take that out, it seems like it's taking us out. And this is a model that was developed by nurses for nurses. Nurses are the leaders in this model. Yes, we know that most teams are interprofessional and often interdisciplinary, but we like to think that nursing can be the leader of these teams. So that is why we keep the P. You cannot separate what nurses are doing from the processes. So we think the P deserves to be preserved.
And if you're like me, you may be wondering about that, having seen published EBQI, PI initiatives. And Julie asked me a simple question. She said, as it says here on this slide, basically, what process change does not impact nursing practice? So we challenge you with that question. What change, if you're wondering, is this process, is this practice? What change does not impact us? And I did not have a response. And that is one of the many reasons that the mountain model is based on EBPQI methods and why we keep the P.
Okay, so as Jane said, the foundation of the mountain model is the evidence, and we have labeled labeled this foundational layer as being the research evidence, because the research evidence is the highest quality evidence that you will find, and it will be based on the hierarchy of study design, quality, etc. But there is other evidence, and that does go in this level. Even anecdotal or observational and unpublished evidence is still evidence, and it goes here because that is what you are going to be building your determination of a practice change upon. And in that assessment of the evidence, we just want to remind you that you need to critically appraise it. And these are just some of the critical appraisal tools that are developed. And we'd like to draw your attention to one tool in particular, and that is the EBPQI critical appraisal tool. This tool was developed by Jane, myself, and our good friend Stacy Reynolds. And you can use it to critically appraise any evidence-based practice or quality improvement results that you identify in your evidence search. So you can start with our problem, Jane.
So let's get right into an example. Low meningitis vaccination rates in adolescents. So this is the problem that is at your clinical site. So the first thing that we're going to do is search through the research and find that meningitis vaccine rates are lower than other vaccination rates in general, particular place where you are, where you're seeing patients. And then next, there's a synthesis of evidence that provider recommendations actually improve vaccination rates. Patients trust their providers. So that is what you find when you go through and do your synthesis at the EBP level.
And so you take that research evidence that you just found and you critically appraise it and you synthesize it. Then you add your clinical expertise, your patient's preferences or their culture, and you can answer that question that Jane was showing you that has a little like circle back, because you need to ask, is there enough strong evidence to change your practice? If there's not, then it's a problem that needs more research. If there is, then you should be able to determine the recommended practice change, not based just on the research evidence or other evidence, but on research evidence, your experience and expertise, and your patient's preferences and culture, so your patient population. And this is where, as Jane mentioned before, you can use additional models. You can use the Iowa model, Johns Hopkins model to kind of fill out this process, if you will. But this is one thing we really like about the mountain model is that it is flexible and simple at the same time.
So then that internal evidence level that is often missing that we see in some of these D&P projects. So this is where you're going to look at these benchmarks: cost, quality, safety, patient-oriented outcomes, satisfaction, and depending on the problem, many more things. And so what you find here supports your problem. Locally, only 60% of people that are eligible are getting that important vaccination. So that's low. And so you're going to take that to build on our next step.
Yeah, so now that you have both external and internal evidence, you are going to be able to develop a purpose for your project. And in this case, we'll say that's to implement provider recommendations, provider recommendation discussion. And then we are going to develop aims that are SMART. So they're specific, they're measurable, they're achievable, they're relevant, and they're time bound. And there are three different types of aims. There's process aims, outcome aims, and balancing aims. And we'll give you some examples of those.
So to start, under the number 1, this is a process measure. So we're looking at a process. Nurse practitioners will document the conversation with the provider and the recommendation in the EHR for 85% of patient encounters. So that's the goal there. And then number 2, an outcome measure. What are we looking for? And this, out of the 3, this is typically the easiest one to make. And this is often where I start and my students start, is with the outcome. There's not a particular order, but the outcome is that the meningitis B vaccination rate increased by 10% within 6 months of the practice change institution. And you can see with these first 2, these are realistic goals. We're not asking for 100%, compliance over a short amount of time. We're looking at what would be achievable. And then for the third one, the balancing measure. And I usually save this one for last because this one is the most difficult for myself and my students. But the average patient visit time will not increase. So by having these improvements and doing what the literature says, we also don't want to increase the time and hopefully, increase cost in those things. So you want to have that balancing measure to make sure that the change is not causing undue negative consequences, is really the purpose of the balancing measure.
And if I could just add, the process measure is usually going to be something that you notice a change in first. So for example, in this case, if you were asking your providers to document a conversation with their patients about meningitis vaccine recommendation, if you didn't see that was happening in your chart reviews or your chart audits, then you can be pretty darn sure that your vaccination rate is not going to go up. So right away you need to figure out why, and you need to make a change, and you need to do that iterative figuring out of what's not working. So, that's why process measures are so important.
Absolutely. Julie, just out of curiosity, is there a particular order that you write these in?
I usually write the outcome measure first. It's easiest. Obviously, it's what we want, the change we want to see in our problem, right? Our problem was low vaccination rate, so we want to increase our vaccination rate. So yes, I always write that one first, and then I say, now, how am I going to know that people are doing what they're supposed to be doing, the behavior that they're supposed to change to make this outcome measure change? And then I do that. And yes, balancing measures are more difficult, but they're very important because you don't want to have unintended consequences from your practice change that
And I see
outweigh
that
the good.
absolutely. And I see that one, I don't know the reason, maybe because they're more difficult, missing in a lot of the published
Oh,
literature. But we need
definitely.
all 3.
Yeah. And so one of the things that your team decides to do is that you make a little process map for how you're going to make this practice change happen. So in this case, you've got a team member doing preclinical review of your eligible children and adolescents and young adults, and that will have the vaccine just pending. And then your provider should be discussing that recommendation with the patients when they are in the office and documenting it so you will know if it's happening. So it wasn't documented, it wasn't done. And then the team member can administer the vaccine and document that it was done. So you have all the pieces you need here. And it's not really a very complicated practice change initiative, but everyone should know their part in it from this process map.
Absolutely. So now we've arrived just under the snow cap at that quality improvement level that we discussed. And this is where you choose, based on your problem focus, which of these which of these models is going to be the best one for your particular initiative. And you see, this is similar to the nursing process with diagnosis, planning, implementation, evaluation, but of course, always starting with assessment and that movement, but it's over time. And you want to have multiple cycles so you can see and assess the progress here and make, unlike research where we're narrowing down and we want to control and keep everything very tight, for an EBPQI initiative, this should be made available to everyone who qualifies in that particular population. So in our example, anyone who is eligible for a meningitis vaccination who hasn't received it should be getting it. So there'll be no control group. There'll be none of that research language in here. And quality improvement, that using a model there will help you see that over time, unlike a research study where it could be pre and post a process change. That wouldn't tell us much. And unfortunately, a lot of DMP projects are like that. We want to see what happens during your third or fourth PDSA cycle, for example, and you will determine that based off of a variety of factors. Julie, anything to add on the QI level?
No, I just always love to remind nurses that we are experts in the nursing process, which is very similar to the EBPQI process. So it's not anything new to you. It's just maybe some new words and a broader way of looking at things with populations instead of individuals.
For sure.
So, like Jane said, this is an example of how you should present the data that you collect in your EBPQI initiative. So in this case, we're evaluating the effectiveness of that provider discussion with patients and recommendations. And we have plotted this on a monthly basis. And we can show what was going on. You know, you see that we knew it was around 60%. And you can see that average before change one was around 60%. We had change one, we had some improvements, and then we identified something that was less than optimal. So we made another change in the practice, and then we have continued to obviously increase the meningitis vaccination rate from this quality improvement initiative. And we have gone beyond goal. Our goal is there at the 10% above where we started. And so this picture, this, as we call it, visualization of the outcome measure says it all. Picture's worth 1,000 words. And that's what's so wonderful. So much better than looking at a table with p-values, don't you think?
I certainly do.
I am biased, of course, but
Well, and this is true when we think about the mountain model as a whole umbrella framework, this is why this information should not be uncoupled from EBP, because those EBP models end basically at implementation. Just do it. But we have to look at this over time. And as you said, Julie, this is a lot more powerful to a team that has made time to invest with you. So think about in our example here, the staff that are pending orders and all of this. they can look on a bulletin board and see this metric improving versus trying to figure out what kind of statistical significance or something was there for a practice change that should be clearly represented as it is in this example.
And in this example, we're representing the monthly rates, but you could have just as easily have weekly rates and be evaluating this on a weekly basis.
So something that as we said, it's important to think about dissemination from the beginning. And then here we are at the top of the mountain, which really is the pinnacle of a practice change. And we've been looking at some of the published literature and using the EBPQI critical appraisal tool that we talked about earlier. And what we found is that some published reports are not actually EBPQI. They were, for example, a pre and post research study. And you can't use a critical appraisal tool of EBPQI on a research study. You would need a research critical appraisal too. So that's something to note when you think back to that second level of the mountain and critical appraisal, that it's really important to have your methods right, but because it impacts everything else all the way up to dissemination. And we need to get good exemplars out there that clearly articulate what EBPQI does and the steps of it. The goal of this is always to improve health and healthcare. We don't need to know if meningitis vaccine is a good vaccine to do. We're not comparing something. We are trying to optimize it so that say this is published or presented, someone did this, you did this initiative, that others could then benefit and transfer those results into their organization. So it is critical.
I'm going to stop sharing for a minute and we will finish up just by telling you thank you. We did have written a second book. We just like you to know. So if you want to learn more about how to use the mountain model in DNP projects or in practice, this book is comprehensive. And in addition, it has chapters on using the model for program evaluation projects and for policy analysis projects, which are two other types of projects that you might consider doing for your DNP project.
So Julie, there is a little bit of information in that book, but the three methods that you're talking about, that's going to be in the DNP project comprehensive guidebook that's going to be coming out in 2026, right? Program eval. Okay, so yes, we have a series of these, and the first book, the initial one, has won numerous first place awards. And again, as we said, this really came from a need. We are very passionate about improving care for patients and populations everywhere. And we have found when people look at the mountain model, which is freely available, you don't have to buy our books. It's open access in the American Journal for Nursing, as is the critical appraisal tool. And so you can download those on your own. If you want more information, more examples, we have these books, the introductory book, the leading book that Julie showed you for DNP and MSN prepared people, and then the forthcoming DNP project guidebook that has some EBPQI information, but also the other types of projects. So we hope that those will be valuable resources for you. And again, please remember with the mountain model, you can use other models within it as long as you are getting both of the paradigms so that you can really entrench those practice changes so that more people can benefit.
And lastly, we'd just like to say that we hope that you will strongly consider using this model in your projects and that you will join us in trying to make nurses be the people who finally get evidence into practice faster than it currently is occurring. Thank you.